Hello everyone, for this video we will go over chapter 37, chapter 38, and chapter 39. Chapter 37 is Digestive System Introduction. An overview of the anatomy and physiology of the digestive tract. We'll start with the functions of the digestive tract, or ingestion, digestion, absorption of nutrients, and elimination of wastes. Anatomy and physiology, it starts with the mouth. In the mouth, we will see the teeth, and the teeth cuts and grinds the food. There's also salivary glands in the mouth that secretes saliva, which is a water solution that contains this enzyme amylase, and it helps with to start the digestion of the food that we eat. Pharynx. In the pharynx or the throat, there is an epiglottis, and this one is the flap that covers the airway. And again, it's like a trapdoor to prevent the food from entering the respiratory tract when we swallow. Now we have the esophagus. This is the pipe. This is the circular, wave-like contractions of the muscles of the digestive tract propel down food to the stomach. Okay. After the esophagus, there's the stomach, and in the stomach there's three sections: the fundus, the body, and the pylorus. In the stomach, the food is mixed with the gastric secretions until it becomes a semi-liquid, the chyme. Again, so the food that we eat, we swallow, it reaches the stomach and it gets mixed with gastric secretions, and it becomes a semi-liquid mass that is called a chyme. After the stomach, the food will go to the small intestine, and in the small intestine, the chemical digestion and absorption of nutrients take place. I will highlight this. So if we encounter a question where it's asking us, where does the absorption of nutrients take place in the digestive tract? So this is the answer: the small intestine, because that is where the chemical digestion and the absorption of nutrients take place. The small intestine is approximately 20 feet long. It's the duodenum, the jejunum, and the ileum. And then after the small intestine, we have the large intestine and the anus. And in the large intestine, this is where the absorption of the water from the chyme happens, and to eliminate the remaining solid waste in the form of feces. Okay. So this is the picture of what we just talked about, the digestive tract. It starts with the mouth, and in the mouth there's the tongue, the salivary glands, and then it will go to the throat, which is the pharynx. From the throat, it will go to the esophagus, which is the pipe, and somewhere here we have that epiglottis, and that is the flap. It is like a trap door that when we swallow, the food will go to the esophagus instead of going into the trachea, right? The trachea and the esophagus is like next to each other. This gray one right here, that's the trachea, and then next to it is the esophagus. So that epiglottis is kind of like the trap door here, and it closes the trachea whenever we swallow, so that the food will go to the esophagus. After the esophagus, there is the stomach. The stomach has the three parts. The top part is called the fundus, and then the body, and then the lower part right here is the pylorus. Okay, and on top right here, in between the esophagus and the stomach, there is a sphincter. It's kind of like a trapdoor again. It's a muscle that contracts and relaxes. And what that sphincter does is that it's preventing the hydrochloric acid or the acid in the stomach, the liquid in the stomach, to go back up to the esophagus, because if it does, it's harmful. Okay, so there is what we call an esophageal sphincter. Okay, and it's between here, the esophagus and the stomach. Then here, between the stomach and the small intestine, is what we call the pyloric sphincter. Okay, and it does the same thing, that it keeps the liquid or the materials in the stomach to stay in there until it's ready to go down. Okay, same thing as the esophageal sphincter, they open or they contract and they relax. And then after that, there's the small intestine, the duodenum, the jejunum, and then the ileum. After the small intestine, it's connected to the large intestine, and the large intestine starts with the ascending colon. Colon is what the enlarged intestine is what we call the colon, colon. Ascending colon, transverse colon, and then the descending colon, and then the sigmoid. And then after the sigmoid, the rectum, and then the anus. In this picture also, it's showing us some of the accessory glands. Like the liver is an accessory gland because it helps with the digestion. There's some enzymes that is coming from the liver that is helping us with the digestion. Also, the biliary tract is like the green one here, and those are the gallbladder and the bile ducts, and they are helping also with the digestion. The bile that is in this area, they flow from the liver to the gallbladder, and then in the gallbladder the bile is stored, and when it's ready, it will be released to the small intestine, to the duodenum, so that it can help with the digestion of and absorption of fats. And then this yellow part here is kind of hard to see because of the picture is not showing it clearly, but this is the pancreas, and again it's an accessory gland of the digestive system. And with the pancreas, it helps because it does have those enzymes that will help with the digestion of proteins, fats, and carbohydrates. And those enzymes are trypsin, amylase, and lipase. In addition to that, the pancreas, they have the alpha cells, and these alpha cells are the ones that produce and secrete glucagon, and then the beta cells produce and secrete insulin. And glucagon and insulin, they help with the regulation of glucose in the body. And this is just a review of the um, information regarding the accessory organs that I just talked about. So this is the liver, and then the bile is produced in the liver, and it passes through that cystic duct and into the gallbladder for storage, and then the bile helps emulsify fat, and then that bile also will flow again from the liver to the gallbladder and then to the small intestine, which is the duodenum. Anatomy and physiology of the pancreas, we just talk about the enzymes that helps with digestion and proteins, fats, and carbohydrates. And again, they are called trypsin, amylase, and lipase. And also in the pancreas are the alpha cells that produce and secrete glucagon, and beta cells that produce and secrete the insulin. For the glucose metabolism and protein metabolism, the glucose, it gets stored when there is an excess glucose from the diet that we eat. It will be taken up to the liver, and then it will be stored as glycogen for later use. Then the fats and the protein, they are broken down in response to the low blood glucose level, and the molecules are used to make new glucose. Okay, so it gets stored in the liver, and then later on, when we need it, when the body needs it, then it can be converted into glucose. The protein metabolism, ammonia, whenever the body process or starts the metabolism of protein, there is what we call a byproduct, and that byproduct is called an ammonia, and this ammonia is acidic, and it's toxic in the body. So that's why there are conditions where this ammonia level gets too high in the body and it doesn't get secreted. It's toxic, um, and it's harmful if it's too much in the body. So that's why we need to make sure that the body is excreting that ammonia, which is a byproduct of the protein metabolism. These are the age-related changes. The teeth are mechanically worn down with age. The jaw may be affected by osteoarthritis. So osteoarthritis, there will be changes in the bones. It becomes brittle. It becomes a little bit more um, deformed. So the jaw will be affected because it is made of bones. So patients that have osteoarthritis that uses dentures, maybe it used to fit them, and then when the osteoarthritis um, progress, then they may not be able to use their dentures as effective as it should be. And then they will have a significant loss of taste buds. Xerostomia is a dry mouth, and it's common. And how do we help them in this situation? Um, we can help them by providing them oral care. Oral care, it can aid with xerostomia or dry mouth. Walls of esophagus and stomach thin with aging, and then secretions lessen, again making it less more dry. And then the production of the hydrochloric acid, which is in the stomach, and the digestive enzyme decreases. Gastric motor activity slows. No significant changes in the small intestine. The liver changes include reduced blood flow and delayed clearance of some drugs. Large intestine, the muscle layer and mucosa atrophy. The movement of the colon content is slower. So that is why constipation is common, in addition to all the medications that they are taking that have a side effect of constipation, the movements of the colon contents is slower. Anal sphincter tone strength decreases, and this could contribute with holding the bowels. In addition to the movements of colon contents slower and the medication that they take, um, other things that could contribute to constipation are lower or low fluid intake, the lack of dietary fiber, inactivity, medications, depression, and hypothyroidism. Diagnostic testing and procedures, the endoscopic examination or endoscopy. This will be a camera guided tube, and it will be inserted in the patient's mouth through the esophagus, through the stomach if it needs to reach the stomach, or wherever it needs to visualize. The nursing care that we need to remember for endoscopy is that patients should be NPO or nothing by mouth for 6 to 8 hours before the examination. Radiologic studies or the imaging, one of them is the barium swallow. So with the barium swallow, patient will be given a barium or like a dye, and they will swallow it, and it will help with like illuminating the GI tract while we are doing the imaging, so that it will be a clearer picture. Now, before the procedure, patient will have to do a bowel cleansing, and we will give them medications, and that medications will help them move their bowels like multiple times until the GI tract is clear and clean. Then after the procedure, we are going to make sure, um, for the nursing care, is that patient will eliminate the barium in their body. And how do we know? We know because until all barium has been eliminated, the stools are going to be white or gray in color. And obviously, how do we do it is we would push fluids so that the barium or the dye can be eliminated from the body. Liver biopsy is when we will remove a liver tissue for examination. However, after um, a liver biopsy, because this one is done either through general surgery or a needle aspiration, meaning that they will insert that needle and they will like kind of like remove or clip a little bit tissue for examination. We as nurses need to monitor their vital signs at the same time for signs of blood loss because of this. Signs of blood loss are tachycardia, restlessness, hypotension, and pneumothorax or pneumothorax. And signs and symptoms of pneumothorax are restlessness and tachypnea. For labs, we will look at those laboratory that could tell us how the liver is doing, like the bilirubin level, um, ammonia level, then the PT-INR, prothrombin time, or INR is international national normalized ratio, and the serum enzymes. Also, some of the pancreatic enzymes should be tested, like the serum amylase, lipase, to check how the pancreas is doing. Also, glucose level, calcium, and then triglycerides. Now, occult blood test. This is when we collect a stool specimen, the poop of the patient, and what we would do, or what we are looking for, is blood, a hidden blood in the stool. That's why it's called occult, because occult means hidden. So this one is when we collect that stool specimen, send it to the lab, and then they are going to check if there's blood in the stool that the naked eye cannot see. And when that is positive for a occult blood test, and that means there is some kind of bleeding in the gastrointestinal system. So this is endoscopy, and again, this is a flexible tube and has a camera on the tip, and it's connected to the monitor so that we can visualize the inside of the digestive tract. Patient will be sleeping during this procedure. They need to be under anesthesia and sedated when this happens. So patient's not awake when we're doing this. These are the medications that we use for GI disorders or GI disease. First one's antacid, and this neutralizes the acid in the stomach, that hydrochloric acid. Medications are calcium carbonate, magnesium hydroxide, aluminum hydroxide. But remember that antacid will interfere with absorption of oral drugs if given within 1 to 2 hours of each other. So that's why when we are going to give antacid to the patients, then we want to make sure that it's given um, at least 1 to 2 hours apart from other medications, because it may interfere with the absorption of the oral drugs. Anti-ulcer drugs like ranitidine and famotidine, they reduce the secretion of that gastric acid, and they can also help with healing gastric ulcers. And this is given with or after meals, with food or after food. We also have omeprazole or Prilosec, and this one inhibits gastric acid secretion, so it kind of like stops it or slows it down, making the gastric acid um, level low. Sucralfate or carafate, what it does is it forms, when the patient swallows it, the carafate or sucralfate forms a protective gel that coats the lining of the stomach. So if the patient have that gastric ulcer, it's very helpful, because what it does is it's coating the lining of the stomach, so it will help. It's like a protective gel from the hydrochloric acid. And this medication is given on an empty stomach 1 hour before meals and 1 hour before antacids. Laxatives, common ones are magnesium citrate, magnesium hydroxide, bisacadyl or dulcolax, senna or senacot, docusate sodium. This is the more common one, colace, Miralax or Galightly, lactulose, and xylem or metamucil. So the trick for laxatives, or the nursing care for laxatives, is that to make sure that our patient is drinking adequate fluids, because there is a risk for dehydration. Also, um, for docusate sodium, the colace, it prevents the constipation by making the fecal mass softer. And how does it do it? Is it's pulling more water from those um, masses. So or fecal masses. That's what I mean. So when we are giving these medications, because it's pulling those water from the fecal mass inside the large intestine, what we need to do is to make sure that the patient is drinking enough water. Now, lactulose is a medication that can also be a laxative, and it can also treat a hepatic encephalopathy when the this hepatic encephalopathy is when the ammonia, remember the ammonia from the byproduct of the protein digestion, when this ammonia gets retained in the body, then we can give the patient lactulose because it helps with the promoting passage of the ammonia through the rectum. And that when that ammonia level gets too high, it's what we call a hepatic encephalopathy where the brain is actually affected. So that's why we can give the patient lactulose because it can help treat hepatic encephalopathy, which is when the brain is affected due to a high level of ammonia. More drug therapy, antidiarrheal drugs like the common loperamide or Imodium. That's always the first um, medication that we would give a patient that have a diarrhea. And then if that doesn't work, then we can always give them a diphenhexylate or Lomotil. Antiemetics can help with nausea and vomiting, and this medication ondansetron or Zofran is the most common antiemetics that we would use. Antibacterial and antifungal and anti-inflammatory, if there's an infection and inflammation that's going on. And then some other classes are like vitamins and minerals, especially for patients that have a vitamin deficiency, albumin, diuretics, hormones, antihypertensive agents, antispasmodics, and pancreatic enzymes in it. Common therapeutic measures, these are what we can do to correct issues in the GI. First one's the gastrointestinal intubation. One of them is like an NG tube, and that is when we insert the tube through the nasogastric in the nose and then in the throat to the esophagus to the stomach. So, but when we do this, always remember that placement is critical because remember that in the earlier part of the chapter I did mention that the esophagus is next to the trachea. So when we insert a tube and we want it to go to the esophagus, there is a risk that it will go through the trachea instead of the esophagus. So that's why placement is very critical. Um, Also elevating the patient's head when that tube is in 30 degrees, at least 30 degrees. Monitoring the residual to help preventing overfilling of the stomach. So after we insert the tube and then we are going to like give, for example, feeding through the tube, we have to make sure that we are monitoring a residual. Residual is when we would aspirate. We would use like an aspirating piston syringe, and we would pull it and then check if there's what we call a residual. When that happens, we have to make sure we are putting it back, number one, and then we are notifying the doctor because monitoring the residual is helping us preventing overfilling of the stomach. So if we are giving feeding and obviously we are getting a lot of residual, then that means that the GI system is not absorbing it properly. So something is wrong. All right, give me 1 second. All right, dumping syndrome. This is one thing that we need to remember. Okay, dumping syndrome happens when there is a rapid movement of the feedings from the stomach to the intestine. Okay, and when that happens, patients will show signs and symptoms. They will have like they will be sweaty, there will be an abdominal distension, dizziness, weakness, and rapid pulse rate, nausea, and diarrhea. Okay, again, remember the dumping syndrome, and this happens because of the rapid movement of feedings from the stomach to the intestine. Okay, patient will show these signs and symptoms. All right. TPN, we will go over this in a little bit, and then surgery. This is the NG tube or the nasogastric tube I was just talking about in the previous slide. It will go past the nasal or the nasal part of the body. That's why it's called nasogastric. And then it will go past the esophagus, going to the stomach. Okay, so this is an NG tube, and this is what I was talking about earlier on, that we have to make sure that placement is being checked. Placement is confirmed by imaging, X-ray. Okay, because we don't want this to be going into the trachea, going into the lungs, and then complications happen. This is a gastrostomy tube or a G tube. Same concept as the NG tube. The only difference is that it is inserted through the skin, right about here, and then it stays in the stomach. Okay. Um, Another thing that we need to remember for G-tube is checking of the residual, right? This tube, we can connect a what we call syringe, a piston syringe, and we will pull and aspirate to check for residual. There should not be a lot of residual when we're giving a patient some feedings, because in a normal situation or the normal process should be once it gets to the stomach it starts digesting and it starts going to the small intestine, right? So if you're feeding a patient and then you check for the residual and there's a lot, then obviously something is wrong with that process. Head of the bed should always be elevated, and placement also is critical because it could be dislodged into other parts of the stomach. This is the TPN or total parenteral nutrition, and this TPN is same concept as the nutrition bag that we give to the G-tube. However, this goes through the veins, okay, through the big blood vessels. And again, we will go over this in chapter, I believe, 38. But this is how a TPN bag look like. And the bag, and then it's connected to a tube, and this tube will be connected into that. Imagine it as a very big IV line because it's connected to the big veins in the body, and these are nutrients that go through the veins. Okay, which of the following is not considered a main part of the digestive tract? Answer is liver, because that is an accessory gland. Which is an age-related change in the lower digestive tract? Answers B, With aging, the muscle layer and mucosa atrophy. Muscle tone decreases, as does the speed of movements of the intestinal contents. The anal sphincter tone decreases, not increases. All right, now we are moving forward to chapter 38, which is the upper digestive tract disorders. The upper digestive tract starts in the mouth to the pharynx to the esophagus and then the stomach. Okay, that is the upper digestive tract. Age-related changes, we already went over that. We already talked about the gastrointestinal intubation, which is the G-tube feedings. And this tube feedings is delivered by gravity flow or by infusion pump. And again, it's critical to confirm that the tube is in the correct place. Okay, before we administer the feedings, we would do an x-ray, radiographic x-ray, to confirm this is the most reliable method. However, there are other ways so we can check if the tube is in place. If the facility is supporting um, or we can do like a pH checking. There is a paper that is checking the pH. What we would do is that we would aspirate or pull some of the material from the tube, and then we will put it in the paper and then check the pH level, and then it will tell us if it's in the gastric or the stomach or it's not. Placement should be checked every shift. Again, head of the bed should be elevated, Fowler position, to reduce the chance of aspiration. And then the residual that I was talking about earlier on, before each feeding is checked. All right, some nursing care for tube feedings. We want to make sure we are obtaining the correct formula. There are different formulas that we could give the patients. So we want to make sure that you're following the correct formula that the doctor ordered for the patient. Tube feedings may be diluted when first started. Usually they would come in a package, so we don't have to dilute them anymore. But if you do, then um, you have to follow the order. Stop feeding if the patient has nausea and pain. And again, dumping syndrome may occur with rapid feedings of concentrated formula. Dumping syndrome, once again, is when the patient will be sweaty, patient will have abdominal distension, diarrhea, okay, and this occurs with rapid feedings. And then the movement of the feeding from the stomach to the intestine is too fast. Gastrointestinal decompression is what we do for the relief or prevention of distension. The book showed us the Levine and gastric sump tubes. There's a picture in the book that we can check. Chapter 38. Monitor the patency of the tubing when we're doing gastrointestinal decompressions, and then also through the 11 or the tubes, the gastric tubes, irrigations may be ordered. Okay. Monitor for electrolyte and fluid imbalance. TPN. So this is the bag we were talking about earlier on, and again, this is um, a bag that or a nutrition that is connected into a large vein, usually in the subclavian artery, and it's inserted um, into that subclavian artery, feeds into the superior vena cava to allow dilution of the concentrated feeding. So that's the reason why this TPN is in the subclavian artery. is because it allows of subclavian. It allows for rapid dilution of the concentrated feeding. Okay, that solution, that bag itself, contains glucose, amino acids, vitamins, and minerals. Lipids are not mixed with TPN solution. So if we need to give lipids, it should not be mixed with the bag. Now, sterile technique. I will highlight this because it's very important to remember that when we are dealing with TPN, we have to make sure that it's sterile. It's a sterile technique because they're at high risk for infection, because again, that bag is connected into a catheter, and that catheter is threaded in the subclavian artery that goes to the superior vena cava, goes to the heart. So if a pathogen gets in, then it goes directly to the superior vena cava, which is very harmful or could even be fatal, right? So that's why we want to make sure we're doing sterile technique. Now, we also want to monitor for signs of infection, okay? And so we will monitor changes in the vital signs. We will monitor patient don't have a fever, right? Because fever is a sign of systemic infection. So we don't want patient to have um, those signs of infection. Monitor flow rate to prevent circulatory overload. Also, changes in blood glucose could happen. So I will highlight that. Um, that's why we are monitoring them for blood sugar changes. That bag of TPN contains, again, glucose, electrolytes. That's why we are monitoring them for changes in the blood glucose. Label the TPN lines and don't use it to administer drugs. Never, ever, ever give medications through the TPN lines. Keep tubing differentiated between TPN lines from small bore enteral feeding tubes. All right, now let's talk about disorders. Anorexia is the first one. Anorexia is a decreased appetite. And there are possible causes for anorexia: patients that have a nausea, the decreased sense of taste or smell. So imagine eating a food without being able to smell it or taste it. That contributes with the decreased appetite. Mouth disorders, it would be uncomfortable for the patients. Medications too, those side effects of medications, let's say dry mouth side effects, it could affect with the appetite of the patient. Emotional problems too. With medical diagnosis, the weight may be monitored over several weeks, and that's when we will see that there is a decrease or there is a weight loss. Also, we would do labs like serum hemoglobin, iron, total iron binding capacity, transferrin, calcium, folate, vitamin B12, and zinc. And then we will check for the thyroid function tests. How to treat this condition is correctable by by assessing what is causing the anorexia. So, for example, it's because of maybe depression or some emotional disturbance. Then we want to address that so that we can correct anorexia. However, sometimes there's no physical cause that is found. So we would help the patient by giving them nutritional supplements. Like, for example, those those milkshakes that is in the bottle, those are nutritional supplements that we could use for the patients. Right? When assessing patient that has anorexia, we would see that they will have like chronic hospitalizations. There will be a weight loss. Symptoms would be pain, nausea, dyspnea, and extreme fatigue. And then assess for malnutrition. We would look at the gums, hair, skin, and teeth. And what you want to see is a healthy mucous membranes, right? A pink gum, um, teeth that looks healthy, skin that is not dry, and then hair that is um, evenly distributed and looks healthy. Okay, because we are assessing for malnutrition. Interventions. Again, when it comes to interventions, it really depends on what is the cause of the anorexia. However, what we can do usually is to make sure that we are helping them with oral hygiene before and after meals. We're going to assist the patient with oral hygiene before and after meals, teach proper oral hygiene, relieve the nausea if that is the problem. Um, Also, before serving meal tray, remove bedpans, emesis basins from site, and then deodorize the room if necessary. If possible, socialization during mealtime should be encouraged. Also, respecting foods and dislikes, likes and dislikes. Positioning the patient comfortably, making sure that their head is elevated, they can reach the utensils, they can reach the food, easy access to the food. For those patients that have feeding problems, like they are having trouble eating, what we can do, some of the interventions we can do are proper positioning, arrangement of the meal tray, providing their assistive device. Sometimes we would give them those what we call weighted utensils, where it's kind of like thick on and heavy on the part where they would hold it in the handle. It helps um, with those patients that are having trouble with grasping the utensils. Open the cartons for them, cut the meat, butter bread, and season their food. And then for patients that have trouble swallowing or dysphagia, we call it the tucked chin method, where they would tuck their chin. That's why it's called tuck chin method. They would tuck their chin whenever they would swallow. It helps with um, patients that have trouble swallowing. Stomatitis is a general term for inflammation of the oral mucosa. Could be from trauma, like poorly fitting dentures, some irritants like tobacco, alcohol, poor oral hygiene, pathogenic organisms like bacteria or fungal or whatever pathogens. And a medical treatment is directed toward what is causing it. And then we may give them a soft bland diet until the inflammation is corrected. Vincent infection is a bacterial that causes a metallic taste in the mouth, and then there will be bleeding ulcers in the mouth, foul breath, and increased salivation. This is bacterial, so we can use topical antibiotics and mouthwashes. Also giving them a good oral hygiene, nutritious diet, and then helping them with rest. Patient also may have signs of a general infection like fever, enlarged lymph nodes, and anorexia. Herpes simplex is caused by the herpes simplex virus type 1. We will see like ulcers and vesicles in mouth and lips that looks like this. And this usually occurs with upper respiratory tract infection or excessive sun exposure or even stress. We can give the patients antiviral agents like those um, ointment, or we can give like topical steroids, spirits of camphor as treatment. Aphthous stomatitis or canker sore. This may be caused by a virus, and it looks like this. It's characterized by ulcers of the lips and the mouth that recur at intervals. We can give them topical or systemic steroids. Candida albicans is a yeast-like fungus, or we call this commonly call this thrush, right? Or candidiasis. This is that bluish white lesions on the mucous membranes. Patients that are on steroid or long-term antibiotic therapy are high risk for this, and we treat this with oral or topical antifungal agents. It's called nystatin. Medications can be used. It could be tablets or lozenges. Also, we can give them a liquid nystatin where they would like put it in their mouth, swish it, and then kind of like gargle it and then spit it. This is the picture for the Candida albicans, the thrush. Okay. How do we prevent this? We can help preventing this by helping the patient with good oral hygiene, or if they can do it, then educate them with good oral hygiene. All right, nursing care would be again gentle oral hygiene, prescribed mouthwashes. The teeth and the tongue can be cleansed with a soft bristle toothbrush, sponge or cotton tip applicator. Medication should be given as ordered. Oral cancer is a squamous cell carcinoma and basal cell carcinoma. Risk factors is related to prolonged exposure to the irritants. So smoking is the biggest thing, um, especially tobacco, that is high risk for this cancer of the mouth. Alcohol use also, poor nutritional status, and chronic irritations. Signs and symptoms, there will be a tongue irritation, loose teeth, and pain in the tongue or ear. And then there may be like lesions that will appear as ulcerations, or there will be like sore spots. Also, they may have what we call leukoplakia. And this leukoplakia are those hard white patches in the mouth, and they are pre-malignant. How do we diagnose? We do a biopsy of like suspicious lesions. And to treat is surgery, radiation, or chemotherapy, or a combination of this. Parotitis is the inflammation of the parotid glands, and this causes painful swelling of these salivary glands. This is below the ear next to the lower jaw, and the pain increases during eating because when we put food in our mouth, when we are eating, then the salivary gland gets activated because the saliva needs to be mixed with food, and that's why the pain is increasing when they are or the patient is eating. Treated with antibiotics, mouthwash, and warm compresses, or it could be worse where it becomes like an abscess, and then we will do like a surgical drainage or even removal when it gets really bad. It can be prevented with good oral hygiene in patients who are unable to take oral liquids. Achalasia is progressively worsening dysphagia, and this happens due to the failure of the lower esophageal muscles and the sphincter to relax during swallowing. To treat this, we can give drug therapy, dilation, and surgical measures. Cancer of the esophagus. There is no known cause, but predisposing factors are cigarette smoking, excessive alcohol intake, chronic trauma, poor oral hygiene, and eating spicy foods. Signs and symptoms: patient will have like a progressive dysphagia or difficulty swallowing. By diagnosing this, we will do that barium swallow, CT scan, esophagoscopy, and endoscopic ultrasound. To treat: surgery, radiation chemotherapy to destroy the cancerous tissues, or maybe a combination of these treatments. For esophageal cancer, when we do the assessment, look for signs and symptoms of hoarseness, cough, anorexia, weight loss, and regurgitation. And these are the nursing diagnosis from esophageal cancer. Nausea and vomiting. Nausea is sometimes referred to as queasiness, vomiting, or emesis is what we call it. Forceful expulsion of the stomach contents through the mouth. Complications would be losses of fluids and electrolytes. So patient may have electrolyte imbalance because of that. Also aspiration when they are having the expulsion of the stomach contents, it may go through the trachea to the lungs. Medical treatment: antiemetics. We mentioned the ondansetron earlier as part of the drug therapy. IV fluids to make sure patient is hydrated. Oral fluids may be limited to clear liquids or even withheld, or we can give them a nasogastric tube. When nausea and vomiting happens, we want to assess the onset, frequency, and duration of present illness. When did it start? How long has it been going on? Those things that we have to question. And then when they do vomit, we have to make sure we are checking the amount, the color, the odor, and the contents of the emesis. And then we check the vital signs, and we do assessment, inspecting, auscultating, palpating the abdomen for distension, bowel sounds, and then tenderness. Hiatal hernia is a protrusion of the lower esophagus and stomach up through the diaphragm and into the chest. Um, the cause of this is the weakness of the muscle of the diaphragm in the area where the esophagus and stomach join, but the exact cause is unknown. So there will be an increased intra-abdominal pressure because of some of the reasons like obesity, pregnancy, abdominal tumors, ascites, and maybe repeated heavy lifting or strain. And this is the picture for hiatal hernia. So this is the esophagus and it's connected to the stomach. The stomach should be starting here, right? And then this is the diaphragm. And because of that weakness in that muscle around this area, the top part of the stomach is like sticking out like this, and it's called a hiatal hernia. Signs and symptoms of hiatal hernia. Many people may not have symptoms at all. Others report feelings of fullness, dysphagia, irritation or that belching, regurgitation, and heartburn. To diagnose, we'll do barium swallow, esophagoscopy, and esophageal manometry. To treat it, um, drug therapy, diet, and measures to avoid increased intra-abdominal pressure. So again, that increased intra-abdominal pressure is the one that's contributing to the hiatal hernia. So to correct it, we want to decrease that intra-abdominal pressure. And if needed, patient can have a surgery. Um, it's called angel chick prosthesis, where they would put the stomach back into where it's supposed to be, and then they would put like a little prosthesis to put it or to keep it in place. Surgery may be necessary if severe bleeding or narrowing of the esophagus occurs. Assessment for post-operative care. Patient might have an NG tube in place and it's connected to a suction for like a day or two, and until the bowel function returns, the patient is given only intravenous fluids for nutrition. And then we tell the patient to expect mild dysphagia for several weeks. GERD, or the gastroesophageal reflux disease, is the backward flow of gastric contents from the stomach into the esophagus. Again, this is caused by the abnormalities in the esophageal sphincter, that muscle that I did talk about earlier on, that contracts and relaxes to keep the stomach contents in the stomach. Also, gastric or the duodenal ulcer can cause this. Surgery, gastric or esophageal surgery, prolonged vomiting, and prolonged gastric intubation. If it's not corrected, it can cause esophagitis or inflammation of the esophagus, because again, that hydrochloric acid from the stomach needs to stay there. The environment in the stomach is designed for hydrochloric acid. However, the esophagus is not. So if that stomach contents goes back up the esophagus, then it can cause an inflammation of the esophagus. Signs and symptoms are painful, burning urination that moves up and down, commonly occurs after meals, and is relieved by antacids. To diagnose, it's suggested by the signs and symptoms, and then we can do some imaging. And to treat, we are going to treat it like those described earlier for hiatal hernia, or also we can give them an H2 receptor blockers like the ranitidine and famotidine that we mentioned earlier on. Also proton pump inhibitors like the pantoprazole or omeprazole can help. If medical care is unsuccessful, surgical fundoplication can be done. Gastritis is the inflammation of the lining of the stomach, and this happens when the mucosal barrier that normally protects the stomach from autodigestion breaks down, and then the hydrochloric acid um, is acidic, so that it can cause that inflammation of the stomach. H. pylori or Helicobacter pylori thought to be the prime culprit. Signs and symptoms would be nausea, vomiting, anorexia, a feeling of fullness, and pain in the stomach area. To diagnose, we would do gastroscopy and then laboratory studies to detect occult blood. Then patient will be checked for H. pylori, and this could be done by breath, urine, stool, or blood tests. Okay, if the H. pylori is present along with the signs and symptoms, then we would think that this is a gastritis that is caused by H. pylori. Complication is pernicious anemia due to the lack of intrinsic factors. So intrinsic factors, this is the kind of like a vehicle to cover the vitamin B12. Okay, so let's say this is the intrinsic factors, IF I would call it, and then the vitamin B12 is the passenger. Okay, vitamin B12. That vitamin B12, remember that it needs to go to the small intestine, so it will be um, absorbed. But for it to travel to the small intestine, it needs to have this coat, which is called an intrinsic factors, and that intrinsic factors is coming from the stomach. Okay, so now when there is a problem with the stomach, there is a problem with the intrinsic factor, and then that coating for vitamin B12 is gone, and it could be destroyed before it gets to the small intestine. Small intestine. Okay. When that happens, then obviously the vitamin B12 level will go down, and it's called pernicious anemia. Okay. Pernicious anemia is an anemia or a decrease in red blood cell because the body is not absorbing enough vitamin B12, which is needed for the production of red blood cells. Okay, that's pernicious anemia in a nutshell. All right, medical treatment for gastritis, oral fluids and foods are withheld until the acute symptoms subside, and so we will order them IV fluids for dehydration and nutrition. Medications, the PPI or proton pump inhibitors that we mentioned earlier, like omeprazole, can be given, analgesics for pain relief, and then antibiotics for the H. pylori bacteria. Surgical intervention may be needed as well. When the patient are vomiting, we have to inspect vomited fluids for bright red blood or dark brown particles that indicate bleeding in the stomach. Also, we're going to check the stools for maroon or terry black appearance. Peptic ulcer happens when there is a loss of tissue from lining of the digestive tract, and it's classified as gastric or the duodenal based on the placement. Gastric is in the stomach, duodenal is in the small intestine. It could be caused by drugs, infection, or stress. Drugs, most common are the aspirin and NSAIDs, like ibuprofen, can cause this peptic ulcer. Also, extreme stressful events like shock, burns, and trauma can cause peptic ulcer. Again, the H. pylori bacteria is a common pathogen that we would see also with peptic ulcers. Signs and symptoms, there will be burning pain, nausea, anorexia, and weight loss. If it's not corrected, then patient may have hemorrhage, perforation, or pyloric obstruction, and peritonitis. Medication for peptic ulcer, um, famotidine and ranitidine, or omeprazole, and antibiotics for the H. pylori. Diet therapy, we want to give the gut kind of like a rest. So instead of giving the patient like three large meals, we would give them small, frequent feedings throughout the day. Peptic ulcer, stomach cancer. This begins in the mucous membranes, invades the gastric wall, and spreads to the regional lymphatics, liver, pancreas, and colon. No specific symptoms or signs and symptoms in the early stage, but in the late stage of stomach cancer, patient will have vomiting, ascites, liver enlargement, and an risk factors are H. pylori infection, pernicious anemia, gastritis, and cigarette smoking, alcohol abuse, diet that's high in starch, salt, pickled foods, salted meats, and nitrates. Diagnosis is just about the same. We'll do imaging and then laboratory studies. For stomach cancer, one of our nursing care during the assessment is to monitor their weight changes and then determine dietary preferences, and then also comfort, appetite, and assess for nausea and vomiting. All right, chapter 39 is lower digestive tract disorders. Lower digestive tract, they assist in the breakdown of food into molecules to be used by body cells and moves food through the digestive tract, eliminates waste products. They are the small intestine, the large intestine, all the way down to the anus. Small intestine is usually 20 feet long, and this is the duodenum, jejunum, and ileum. And again, the function is the chemical digestion and absorption of nutrients. This is the small and large intestine. So this is the small intestine in the middle here. And again, it's duodenum, jejunum, and then ileum, and then it will be connected to the large intestine. Liver, gallbladder, and pancreas, we did touch base this. So these are the accessory glands of the GI. This is the liver, the gallbladder that stores the bile for later use, and then the pancreas right here that houses or secretes the glucose, the insulin, and the enzymes like the trypsin, amylase, lipase that helps with emulsification and the digestion of um, the food that we eat. Right. For age-related changes, there's no significant changes in the small intestine, large intestine, the muscle layer, and mucosa atrophy. Okay, for physical examination, we have to remember that for GI, the physical examination is different. We would always start though with the inspection, but after the inspection for GI, you want to listen first before touching. So after inspection, you want to auscultate with the stethoscope before we would do percussion and palpation of the stomach, because if we start doing percussion and palpation when we start touching it, it messes up with the bowel sounds um, in the stomach, so that when you auscultate, because you already manipulated the abdomen, um, it's not going to be accurate. Okay, so that's why when we do a GI physical examination, we do inspection, auscultation, percussion, and palpation. Again, you look, you listen, and then you touch. Laboratory tests. We did talk about the occult blood test, which is the hidden blood test. Again, we will collect a stool specimen and then send it to the lab and check if blood is present. If blood is present, then there's a positive occult blood test, and that means that there's some GI bleeding that's going on. Some of the conditions: obesity. This is increased weight caused by excessive body fat, and the causes are hereditary, problems with metabolism, or psychosocial factors. Complications would be cardiovascular problems. Medical diagnosis: we're gonna check the weight, standard weight tables, we're measuring skin fold thickness, and then we would check for endocrine function tests. To correct, we would do a weight reduction diet accompanied by a planned exercise program. Also, they could go into like a bariatric surgery, like the root NY gastric bypass, sleeve gastrectomy, duodenal switch, or the laparoscopic adjustable gastric binding, and it looks like this. So the gastric sleeve, what they would do is they would cut or remove part of the stomach so that the stomach will be smaller, and it looks like this. And when that happens, patient can only eat small amount of food and then they will feel full right away. With lap band, they would put like this band. It's kind of like the same concept too, like they're trying to like make the stomach smaller so that when the patient eats, they get full right away. And then there is the bypass, where this is the esophagus. It's just going to run, um, and then go straight to the intestine. Okay, so it's just going to touch the very small stomach here, and then it's gonna go to the small intestine. All right, obesity. We did talk about the cleansing, and then the prep before they go into a gastrointestinal surgery, the NPO before surgery. Okay, malabsorption is when one or more nutrients are not digested or absorbed, and it could be caused by bacteria, deficiencies of bile salts or digestive enzymes, alterations in the intestinal mucosa, and absence of all or part of the stomach or intestines. Signs and symptoms we will see, they will have that steatorrhea, or there's an increased fat in the stools, weight loss, fatigue, decreased libido, easy bruising, edema, anemia, and bone pain. Bloating, cramping, abdominal cramps, and diarrhea are symptoms of lactase deficiency. For SPRO, SPRO is based on laboratory studies and endoscopy with biopsy and imaging. For lactase deficiency, we would do like a lactose tolerance test, and then we can do a blood test for abnormal hydrogen levels, or if necessary, biopsy of the intestinal mucosa. So for sprue, celiac disease, tropical sprue, and lactase deficiency, to correct them, it really depends on, or to correct them, we would do like a diet and drug therapy. So for sprue, Those food that aggravate the symptoms should be eliminated from the diet. The celiac disease, this is a genetic malabsorption disease, and the patient should avoid products that contain gluten. For tropical sprue, this is an infectious agent, so we would give patients antibiotics, oral folate, and vitamin B12 injections. Lactase deficiency, we have to eliminate milk and milk products from their diet. Nursing care for the malabsorption, we're going to document the patient's symptoms, check the stool characteristics, eliminate um, gluten from the diet if it's celiac sprue, give antibiotics if it's tropical sprue, and then advise the patient with lactase deficiency of dietary restrictions and alternative products. Again, the milk. Diarrhea is a passage of loose liquid stools with increased frequency. Patient may even have cramps, abdominal pain, and feeling of urgency. Causes could be spoiled foods, allergies, infections, diverticulosis, malabsorption, cancer, stress, fecal infections, and tube feedings, and could be an adverse effect of some medications too. If it's not corrected, it can cause dehydration and electrolyte imbalances and metabolic acidosis. Also malnutrition and anemia. To correct acute diarrhea, we can give them an antidiarrheal drugs like the loperamide or Imodium or Lomotil. Though severe persistent diarrhea may require TPN. Constipation is a hard, dry, infrequent stools that are passed with difficulty, and this is how it looks like inside the intestine of a patient that have constipation. Causes include frequently ignoring the urge to defecate, the frequent use of laxatives or enemas, inactivity, inadequate water intake, diet low in fiber, drugs that slow the intestinal motility, like medications like opioids for pain, diuretics, and antidiarrheal. Diseases of the colon or rectum, as well as brain or spinal injury or abdominal surgery, can cause constipation as well. So the biggest complications is the Valsalva maneuver. So Valsalva maneuver is when the patient is straining too much because of the constipation, the glottis closed, increasing the pressure in the chest and abdominal cavities. When that happens, there is a rapid change in blood flow and the heart rate decreases. This can be dangerous and even be fatal to a patient with heart disease. So that's why constipations need to be addressed because of this reason. It could be fatal to a patient that has a heart disease. Hemorrhoids too can happen, fecal impaction can happen. So how do we correct? Laxatives, suppositories, enemas, or combination for prompt results. Or stool softeners like the docusate colis that we talked about earlier. Senocod or Sena, laxatives that we talked about earlier. Okay. Interventions for constipation is to maintain diet, fluids, exercise, and regular toilet habits. And if there is a fecal impaction, we assess for the impaction by inserting a gloved, lubricated finger into the rectum, and we would be able to feel it. It's hard and it's stuck in there. We would remove impaction following the agency protocol or specific providers' orders. So we could either give them an enema if that is the doctor's order, or we could do like a manual removal of the impaction where we would again insert a gloved finger into the rectum, and then we would kind of like break apart the impaction so that um, the stool can come out. All right, this is Hirschsprung disease or megacolon. So this is how a normal intestine look like. You see how the size looks normal, and then there's this yellow things, which is the ganglion cells, and the ganglion cells are helping with the peristalsis or the relaxation and contraction of the intestine to kind of like help the food move all the way out to the anus. This is a Hirschsprung disease or a megacolon. So this part right here is the affected part. If you look at this, it becomes enlarged, it's big, and there's no ganglion cells. So you can see that number one, feces can be stuck here. It can cause impaction. In addition to that, there's no ganglion cells, which ganglion cells once again is helping with the peristalsis and movement of the fecal mass. So without those ganglion cells and then the enlargement, it gets stuck here. Okay. Usually to correct this, if this is like an inflammation, then we would correct the inflammation. If not, then we might need to remove the affected part of the colon. Liver and pancreatic secretions enter the digestive tract in the So the answer here is the first part of the intestine, which is the duodenum. So it goes by duodenum and then jejunum and then ileum. So the liver and the pancreas, they have these secretions that we talked about earlier on, and they will be secreted into the small intestine, the first part of the small intestine, which is the duodenum. Intestinal obstruction is when there is a obstruction of the intestine that it could be caused by strangulated hernia, tumor, paralytic ileus. Paralytic ileus is when there is a decrease or maybe even stopped peristalsis. Um, Stricture volvulus or the twisting of the bowel. Intussusception is telescoping of the bowel into itself. I will show you a picture later on. And postoperative adhesions. So signs and symptoms of intestinal obstruction is vomiting, possibly projectile vomiting, abdominal pain and constipation, blood or purulent drainage past rectally, abdominal distension, especially with colon obstruction. This is a sample of strangulated hernia. So the small intestine that needs to stay in the abdominal cavity here is outside um, because of this weakened muscle, most likely. Then it's strangulated here, and when that happens, the blood flow to this area is decreased. Um, and look at this intestine, the color here is because there's no blood flow. um, this is emergency. We need to address it right away, otherwise the tissue that is in here without the blood flow is dying. This is the intussusception. Okay, so the small intestine that should be like smooth flow, with intussusception, the part of this intestine here is kind of like telescoping into itself. So it looks like this cross-section view. So this should be connected, right? However, what it's doing is this part right here is telescoping into this part. Okay. When those things happen with intussusception and strangulated hernia, gangrene can happen. Again, the tissue um, will die, and then perforation of the bowel can happen. Shock and death can happen if untreated. How do we correct it? So we will do a gastrointestinal decompression, intravenous fluids, or surgical intervention. Appendicitis is the inflammation of the appendix. We are trying to prevent ruptured appendix when this happens, when the patient has appendicitis, because a ruptured appendix allows the digestive contents to enter the abdominal cavity that can cause peritonitis. Medical treatment for appendicitis is that they will be NPO, and maybe a cold pack to the abdomen may be ordered. Laxative and heat application should never be used for undiagnosed abdominal pain, because once again, when there is an appendicitis, we're trying to prevent the rupture of the appendix, and doing this, like giving them laxatives or heat applications, can cause a ruptured appendix. So laxatives and heat applications never be used, should never be used for undiagnosed abdominal pain. Immediate surgical treatment is indicated. A ruptured appendix, if it did rupture, then the surgery may be delayed 6 to 8 hours while the antibiotics and IV fluids are being given to the patient. We do assessment for appendicitis. We're going to check for the temperature, abdominal pain, distension and tenderness, presence and characteristics of bowel sounds. Before the surgery, patient should be in a semi-Fowler or side-lying position with the hips flexed. If rupture is suspected, elevate the patient's head to localize the infection. Post-operative, we would administer antibiotics, IV fluids, and possibly gastrointestinal decompression. Splinting the incision during deep breathing. So what we could do is we could have them hold a pillow in their abdomen, because we will do like turning and coughing and deep breathing exercises so that we can prevent pneumonia. When that happens, or when we're doing this, of course there is a surgical wound there, there's an incision, and the patient may refuse to do it because of they are scared of the pain, or the incision may open. What we would do is we would splint the incision during the deep breathing exercises. And again, how do we do it? We would ask the patient to maybe hold a pillow, and then put it in the abdomen area, in the incision part, while they are doing the deep breathing exercise. Peritonitis is inflammation of the peritoneum that is caused by either chemical or bacterial contamination in the peritoneal cavity. If it's bacterial, we can treat this with antibiotics. Signs and symptoms are pain over the affected area, rebound tenderness, abdominal rigidity and distension, fever, tachycardia, tachypnea, nausea, and vomiting. Um, Medical diagnosis is the same as other GI diagnosis. For treatment, we can do a gastrointestinal decompression, intravenous fluids, antibiotics and analgesics, and surgery to close a ruptured structure and remove foreign material and fluid from the peritoneal cavity. Abdominal hernia happens when there is a weakness in the abdominal wall that allows a portion of the large intestine to push through. So it looks like this. But reducible hernia is when the hernia are able to slip back into the abdominal cavity. If it's not able to slip back, it's called irreducible or incarcerated hernia. Between the two, the irreducible hernia is problematic because it may impair blood flow to the trapped loop of intestine, causing it to become gangrenous. like the strangulated hernia. That is a medical emergency. This is how it looks like. So umbilical hernia, femoral hernia, then could be direct inguinal hernia or indirect inguinal hernia. Signs and symptoms, there's a smooth lump on the abdomen. And again, if it's incarceration where it's not able to slip back into the abdominal cavity, the patient may have severe abdominal pain and distension, vomiting, and cramps. Herniorrhaphy is the repair of the muscle that is um, done by suturing. Okay, this is to correct the hernia. Hernioplasty, when we use strong materials to cover and reinforce the defect. So we can use something like this. This is a brace to help with hernia. So you remember the picture earlier where there's a smooth lump, and this brace right here, it could help with pushing down um, the lump or preventing it from sticking out. Ask about pain and vomiting, inspecting for abnormalities, and listen for bowel sounds in all four abdominal quadrants. Inflammatory bowel disease. There's ulcerative colitis and Crohn's disease. These are inflammation and ulceration of the intestinal tract lining. With ulcerative colitis, the inflammation typically begins in the rectum and gradually extends up the bowel toward the cecum. The progression of Crohn's disease is different in that it can affect any area of the gastrointestinal tract. Exact cause is unknown, however, possible causes are infectious agents, autoimmune reactions, allergies, heredity, and foreign substances. Signs and symptoms for ulcerative colitis is diarrhea with frequent bloody stools and abdominal cramping. For Crohn's disease, if the stomach and duodenum are involved, symptoms include nausea, vomiting, and epigastric pain. If small intestine is involved, it produces pain and abdominal tenderness and cramping. If colon is the one that's inflamed, it typically causes abdominal pain, cramping, rectal bleeding, and diarrhea. And systemic signs and symptoms include fever, night sweats, malaise, and joint pain. So again, it really depends on whichever area is affected. Again, with Crohn's disease, any part of the GI can be affected. Complications could be hemorrhage, obstruction, perforation, abscesses in the anus or rectum, fistula, and megacolon. We did talk about the diagnosis. Um, so for treatment, we would give analgesics for pain, antidiarrheals for diarrhea, hydrating the patient, and then for nutrition we would give them low residue diet without caffeine, pepper, or alcohol. And then foods that are not allowed include whole grains, nuts, and raw fruits and vegetables. Diverticulitis is when there's small sac-like pouches in intestinal wall. This happens when there's like weak areas of the intestinal wall, and it allows segments of the mucous membrane to herniate outward. Risk factors are like lack of dietary residue, age, constipation, obesity, and emotional tension. And it looks like this. You see that there's like inflamed diverticula, and because of that, there is pain and the other symptoms that we just talked about. For treatment of diverticulosis, high residue diet without spicy foods will be given, stool softeners or bulk forming laxatives, antidiarrheal, antibiotics, anticholinergics. Surgical intervention may be necessary where the affected portion of the colon is removed. Also, when that happens, maybe temporary colostomy will be placed. Colorectal cancer is a cancer of the large intestine, and the people at greatest risk are those with history of inflammatory bowel disease and family history, or patients that have multiple intestinal polyps. Also, high fat diet, low fiber diet, and inadequate intake of fruits and vegetables can be contributory to the development of colorectal cancer. Signs and symptoms: the right side of the abdomen will feel that vague cramping until the disease is advanced, unexplained anemia, weakness, and fatigue related to blood loss. Left side or in the rectum, it will be patient will have diarrhea or constipation, may even have blood in the stools. Stools may become very narrow, causing them to be described as pencil-like. And then there's a feeling of fullness or pressure in the abdomen or rectum. To correct, we will usually treat surgically or a combination of chemotherapy and surgery, radiation. Polyps are small growths in the intestine and usually are benign but can also be malignant, usually asymptomatic and found on routine testing. Complications are bleeding and obstruction, diagnosed by barium enema or endoscopic exam, colectomy for familiar polyposis or Gardner syndrome because of the high risk. Hemorrhoids, either internal or external, are dilated veins in the rectum. Risk factors are constipation, pregnancy, prolonged sitting or standing. Signs and symptoms are rectal pain and itching, bleeding with defecation. External hemorrhoids are easy to see. They appear red or bluish. Looks like this. So again, the external hemorrhage is easy to see, where the internal hemorrhoid are inside, so it's not easy. Diagnosis is by visual inspection, and treatment could be creams like topical creams, lotions, or suppositories to soothe and shrink inflamed tissue. Sitz baths also is comforting, and the provider may order heat or cold applications. Or we can do like a surgery. Um, Outpatient procedures are like ligation of the hemorrhoids, laser surgery as well, and then removal of the hemorrhoid itself is um, called hemorrhoidectomy, and this is done by surgical excision of the hemorrhoids. After the hemorrhoidectomy, we are going to monitor the patient's vital signs for bleeding and then also checking for the drainage. For the pain, cold packs can help, and then we can provide the patient a soft pad or cushion for more comfortable seating, preventing the constipation, like stool softeners, giving them stool softeners. Anorectal abscess is an infection of the tissue around the rectum. There will be rectal pain, swelling, redness, and tenderness, and it's treated with antibiotics followed by the incision and drainage. But ice packs can help, sitz baths, and topical agents. Post-operatively, pain is treated with opioid analgesics, and we educate the patient for the importance of thorough cleansing after each bowel movement and advising the patient to consume adequate fluids and high fiber diet to promote soft stools. Anal fissure is a laceration between the anal canal and the perianal skin. And this could be from like constipation, diarrhea, or Crohn's disease, the inflammation of the GI. Signs and symptoms will include pain before and after defecation and bleeding on the stool or tissue. usually will heal spontaneously but can become chronic. What could help? Sitz baths, stool softeners, and analgesic or surgical excision may be necessary. Anal fistula is an abnormal opening between the anal canal and perianal skin, and this could be developed from anorectal abscesses or related to inflammatory bowel disease or tuberculosis. Patient typically complains of itching and then discharge. Sit baths can promote comfort. Surgical treatment may be needed, sometimes a temporary colostomy to allow the surgical site to heal. Pilonidal is located in the sacrococcygeal area, and this results from an enfolding of skin causing a sinus that is easily infected. And once it is infected, it is painful and swollen and may even form an abscess. To correct it, we would do a surgical excision for drainage, and the care is similar to that of the patient for the patient having patient education to promote normal bowel function is good hand washing and proper food handling.